So it's really my pleasure to welcome Dr. Leslie Caldarelli. Dr. Caldarelli is the medical director of the NICU at Prentice Women's Hospital at Northwestern. She's also the neonatal co-lead of the Illinois Perinatal Quality Collaborative. Dr. Caldarelli received her medical degree at Rush Medical College, completed her residency and neonatology fellowship at the University of Chicago, as well as a fellowship in medical education. Sounds like you're a Chicago native, Dr.
Yes.
Caldarelli. You've been there a long time, but we're really thrilled and honored that you're here to share your experience and the experience of the ILPQC around safe transitions of substance-exposed newborns, an area, as you've just heard, we are really kind of grappling with and trying to operationalize this language that is coming down the pipe. So I'll pass it over to you, Dr. Caldarelli.
Thank you. Thank you for having me. This is an honor to be here and listening to the morning. I've learned so much. First thing I'm gonna do is share my screen and then start talking. Is that working?
That looks great.
Okay, so in preparing for today and listening this morning, I reviewed quite a bit about, or attempted to review quite a bit about Colorado. And then it was also fascinating to go back. We started at ILPQC our, what we call MNO, and I'll describe that in a minute. We started in 2017 and thinking at that point that there was this opioid epidemic that we were going to help mothers and birthing patients and newborns with. And now seeing, Dr. Huang, your slides, and I have some of the similar slides in my presentation, how much worse the epidemic has become. This, what we began in 2017 was just the very beginning of the work we need to do. So what I'm going to talk about today is just a little bit about who ILPQC is, what's happening in Illinois, what is our initiative, and share with you what we've done in Illinois and the future work that we will do and the work we continue to need to do. What does it mean to have a safe discharge? As people talked about this morning, what is a safe discharge and how do we define that, and what does that mean? Talking about what we in Illinois and at ILPQC decided a safe discharge was, weren't quite comfortable with the word safe, so called it a coordinated discharge, which is hopefully similar to this new CAPTA legislation that we'll call it a family care plan. And then PDSA cycles. They weren't as easy as we thought they would be. We thought a coordinated discharge plan would be easy. Here's what you need for a coordinated discharge plan. But we needed to lean on ourselves a lot, on hospital teams and other PQCs to really refine how we improved our coordinated discharge. And then now what's happening in Illinois and Colorado, and what are our next steps. So who is ILPQC? ILPQC is the Illinois Perinatal Quality Collaborative. It joins over 95% of our birthing hospitals and neonatal intensive care units in Illinois. We also include Missouri, just a little bit of the St. Louis area. So we are still called ILPQC, but involve a little bit of Missouri. We, as all PQCs, collaborate with physicians, nurses, hospital teams, patients, public health, and community stakeholders. We work together to implement evidence-based practices to improve health outcomes for birthing patients and newborns. And we use data-driven quality improvement science to improve these health outcomes. Here's our team, our central team that works at ILPQC. And then here's our ILPQC Central. We really stand on the shoulders of our hospital teams and our neonatal, both our neonatal and OB hospital teams. We have a neonatal advisory work group and an OB advisory work group who provides guidance to ILPQC Central. And then we partner with our stakeholders, state health agencies, community associations, and advocacy groups in Illinois. And then also our advisors from a regional perinatal system in Illinois, our patients and family advisors, legislators in the state of Illinois, and our maternal mortality review committee. Our approach is at ILPQC is built on 3 pillars. We lean on the model for improvement and use this model for improvement to create all of our QI initiatives. But ILPQC is founded on these 3 pillars on the left of this slide. We strive to have collaborative learning, a rapid response data system where hospital teams can almost immediately access their data and compare to other hospital teams, and then also provide QI support through monthly webinars, individual hospital QI support. We have twice a year large forums like your forum today that we help to build QI capacity at hospitals. Here's the history of ILPQC. We started a little bit before 2014, but our first initiatives started in 2014. In orange, you can see neonatal, and in blue is our obstetric initiatives. On the neonatal side, we started with nutrition, moved to golden hour, and you can see how many hospital teams were involved at the bottom of each of the rectangles. We've grown ILPQC and also work to improve health outcomes for mothers and babies in Illinois. So in Illinois, in 2017, we identified that there was an opioid crisis problem. We were not as heavily impacted as other states in the country, but there was a problem in Illinois. And so we identified this as an area that we wanted to focus on for our next improvement initiative. This slide Dr. Wong showed, and this was the work we were doing in 2017, had this what we thought at that point was a massive increase, but it was just the beginning of opioid overdose deaths. We also saw in relation to that with increasing opioid use, there was, and opioid deaths within those were pregnancy-associated mortality from opioid-related poisoning deaths. And we saw in 2008 in Illinois, we had 1.1 per 100,000 deaths. And then by 2017, when we were beginning our initiative, had 12 per 1,000. And so we saw this 1,000% increase and said, we need to work with mothers and birthing patients and babies. Of course, with maternal and birthing patient opioid use, there's going to be an increase in neonatal abstinence syndrome rate. And we saw from 2011 to 2018 in Illinois, a 64% increase. Our guess is that this is, as in all the states, that this is underestimated and has definitely increased since 2017. So because of our problem identification, we started the Mothers and Newborns Affected by Opioids, which we affectionately call MNO, Neonatal and OB Initiative. We focused on a spectrum of care for mothers and newborns affected by opioids. We started and we partnered for the first time with the OB side of ILPQC to build an initiative. On the OB side, they focused on screening and linkage to care. And then we joined together in the middle. I should have put an OB star up there also, but optimizing care for mothers, birthing patients, and babies. And then back to the OB side, worked on prevention of opioid use disorder. Our goal on the neonatal, or our aims on the neonatal side, were to decrease the proportion of OENs requiring pharmacological treatment to below 20%, to increase the proportion of eligible OENs receiving maternal breast milk to above 70% at infant discharge, and increase the proportion of OENs discharged with a safe discharge plan to above 95%. And you can see in these slides, not only is this a historical trip through ILPQC and our initiative? It was really interesting when I was developing the slides to see how language has changed around opioid use disorder, how language has changed through our initiative from a safe discharge plan to a coordinated discharge plan, how language has changed. Our initiative is obviously called Mothers and Newborns Affected by Opioids, and now realizing that all birthing patients don't identify as mothers, changing that terminology. So I just want to give the disclaimer that some of these slides and our verbiage is from when we knew less, and now we know better. So here's our key driver diagram. We, as all QI initiatives, developed a driver diagram. We identified as our primary drivers that on the neonatal side, identifying and developing an assessment plan of substance exposed newborns was a key driver. Treating those newborns, how are we going to treat them? And then developing a safe or coordinated discharge. Around our driver diagram, we developed structure measures. Our 4 main structures that we asked hospital teams to develop at their hospital so that we could drive to optimizing care to moms and babies was to increase maternal engagement through prenatal consultation, to engage families and OB patients early on in pregnancy. Through that, we were able to provide expectations, provide anticipatory guidance, and empower and engage birthing patients to know that they were the best medicine for their baby. Standardizing non-pharmacological guidelines for OENs, we focused on Eat, Sleep, Console during our initiative and continue to focus on Eat, Sleep, Console. Standardizing pharmacologic guidelines, knowing that if a baby needs medications, to have it standardized would lead to the least amount of pharmacological exposure for OENs. And then implementing a coordinated discharge plan. Taking care of a patient before they were born, while they're in the hospital wasn't enough. Just to send babies out with in a high stress environment wasn't enough. And so really focused on this after hospital planning. Our process and outcome measures were the percent of OENs receiving a tox test, percent of OENs requiring pharmacologic treatment for NAS, number of days of pharm treatment, percent of OENs and mothers who roomed together during the infant hospitalization. This was a big shift for a lot of our hospitals to get very creative about how to keep birthing patients and newborns together in the hospital. While we were observing the baby and the mother had been discharged, the percent of OENs receiving maternal breast milk at neonatal discharge, percent of OENs discharged with a coordinated plan, and then looking at length of stay for OENs. We had key strategies that we used and hospitals used to implement best practices, implementing standardized identification of OEN with OB, and that's where we partnered, using the 5 Ps to screen moms either prenatally or in triage, and then identifying OENs. Standardizing the assessment of NAS signs and symptoms with Eat, Sleep, Console. Implementing a non-pharmacologic bundle using Eat, Sleep, Console, establishing feeding guidelines, including breastfeeding eligibility, standardizing our pharm treatment, standardizing provider training, stigma and bias, standardizing patient education, and then implementing standardized safe discharge planning. We developed a toolkit. A lot of our work was in partnership with the Illinois Department of Public Health. Our toolkit had a couple of introductory areas, but then 8 key areas that we focused on. So strengthening family care team relationships. We developed with IDPH some handouts in education, neonatal abstinence syndrome, what you need to know, so that mothers and OB patients and families understood neonatal abstinence syndrome. They understood what their role, or hopefully understood what their role was in treating their baby, understood what it might be like going home, or at least asked mothers, OB patients, and families to reflect on what it would be like going home and start to plan for hospital discharge. We also did this through pre-delivery planning. So we developed a standardized neonatal consult, prenatal consult that also empowered, or hopefully empowered and engaged mothers and OB patients before a baby was born. Standardized identification section, provided family education, improved nutrition and breastfeeding, and I'll go over some more of these in depth, optimized non-farm care, standardized non-farm care, and then some of these I've listed already. So things that I've touched upon a little bit, our NAS booklet, What You Need to Know, is a really wonderful resource that the Illinois Department of Public Health and people at IOPQC created that I described already. A prenatal consultation checklist. We asked our OB partners, we have a fetal center, for example, at where I work, that we asked our OB partners to refer to the fetal center to use this checklist. Other hospitals disseminated this prenatal consult checklist to their OBs or partnered with their pediatric colleagues to have them do a prenatal consult. But we developed a checklist of things that mothers and OB patients would need to know and consider before having a patient. Most importantly, the expectation that they would or could stay in the hospital for 5 to 7 days for an observation period with their baby. We have Eat, Sleep, Console materials for hospital teams to use. Eat, Sleep, Console non-farm simulation videos. You can see at the bottom a screenshot of some of our simulation videos on engaging moms in non-farm care, and also teaching about Eat, Sleep, Console assessment of OENs. We developed a breastfeeding traffic light counseling resource. Many hospitals were unclear on when it was okay to breastfeed, when it was, should be a discussion about breastfeeding, and when it was not okay to breastfeed. And so both changing our language around allowed and we allowed this mother to breastfeed, we allowed this OB patient to breastfeed, but also standardizing and disseminating which medications or substances were okay to provide breast milk or breastfeed with and which were not. I'm going to go more in depth into our collaborative discharge plan, but we also developed M&O neonatal folders and OB folders. These were folders that anytime there was an OEN identified, these folders were pulled. So if you only saw a couple of OENs a year, you could pull these folders and every OEN had the exact same treatment as if you were seeing many, many OENs a month. So here's a roadmap of our initiative. We planned for it in 2017. We launched it in 2018 with 88 teams. By August 2019, we had seen our 100th OEN. We developed Eat, Sleep, Console simulation training videos to really allow hospitals to understand and practice Eat, Sleep, Console. We standardized care with the folders that I just described. We partnered with the AAP to develop a e-module on safe discharge. We completed our active initiative in 2020, but as we've seen with increasing numbers of opioid deaths and maternal opioid use, we are still in an active initiative phase. In 2021, we transitioned to sustainability. We at ILPQC are calling it active sustainability. We have teams still collecting data, and we have quarterly M&O calls to keep the initiative moving forward. In April 2021, we saw our 2000th OEN, and then had some of our final sustainability webinars on the OB side, but are continuing to do sustainability on the neonatal side. So as I said earlier, we linked with our OB partners, mothers and newborns affected by opioids. Our goal was to give optimal OUD care to every dyad. So moms and babies, screening and linkage to care, optimizing care for mothers and babies, and then prevention. On the OB side, their goal, as on our neonatal side, was optimal care for every patient every time. The OB side had hospitals use a validated screening tool, assessed readiness for medication-assisted treatment. Another strategy was starting MAT and linking to recovery treatment services. naloxone counseling, warm handoff to community-based MAT, RTS, and OB follow-up. And then their last strategy was promoting respectful care across the clinical team. Here are some of the results that from the OB side. On the left, this is 4 years of M&O, and this is screening. On the left of the screen is prenatal screening, and the right is L&D screening. And so this is 5P screening. The red bar, or the red area, is screening not documented or a missed opportunity. The yellow is screening that was done with a not validated screening tool. And then the green is validated self-reported screening tool, so 5Ps. And so, like I said, the left is prenatal screening. And you can see the beginning of the initiative on the left to February 2022 on the right, and the increase in the green, illustrating an increased use in validated self-reporting screening tool at our hospitals. And then on the right is L&D screening. And so there was more screening done in L&D as opposed to prenatal screening, but quickly reached the goal and then has been able to maintain that goal through sustainability. This is linkage to care. This is the percentage of pregnant persons with opioid use disorder connected to MAT and RTS. Prenatally or by delivery discharge. The blue is MAT and the red is RTS. This is Narcan counseling and prescription offer. And then switching to the neonatal side, our goal was optimal OEN care, every baby, every time. Too many letters. On the M&O side, I've gone over this. We focused on prenatal consult, non-farm care, farm treatment, eat, sleep, consult, M&O folders, and then coordinated discharge. Here are some of our results. This is 4 years of M&O. So more breast milk was provided at infant discharge. Greater than 70% of opioid exposed newborns are now receiving breast milk at infant discharge and maintained through sustainability. This is our change in assessment tool. This is Eat, Sleep, Console versus, compared to Finnegan. The blue is modified Finnegan and the red is Eat, Sleep, Console. And at the beginning of our initiative, 74% of teams were using modified Finnegan and 14% actually this is babies, I apologize. 74% of babies were assessed with Finnegan and 14% of babies were assessed with Eat, Sleep, Console. And then as we did education, our simulation videos and worked together as an initiative, you can see obviously the lines crossing, and now 80% of our babies are screened with receive Eat, Sleep, Console, and only 15% still using Finnegan. This is less farm treatment. In the orange is PRN dosing of farm treatment, and the blue is standardized dosing. At the beginning, 89% of our babies were receiving standard dosing of pharmacologic treatment, and 11% were receiving PRN dosing. And then in sustainability, we've stayed about 60% receiving PRN and not even being started on standardized dosing. And this is our coordinated discharge. At baseline, 2 of 10 OENs had a coordinated discharge plan. And by the first quarter of 2020, we had 7 of 10 OENs having a coordinated discharge plan. This is our length of stay. At baseline, we were 11.4 days in the hospital, and in 2021 and through now, we are about 8 days in the hospital for opioid-exposed newborns. So shifting now to plan of safe care, a lot of this was reviewed earlier, and I'm not going to, one, because this looks incomplete next to what was discussed this morning. But we did at ILPQC start talking about, when we were planning discharge, what is a plan of safe care? We have CAPTA and we have CARA, and these leave it up to states to, as we heard this morning, this leaves it up to states to determine what is a plan of safe care. But in Illinois and at ILPQC, we said, okay, we can develop a plan of safe care. In Illinois, it is, there are not Illinois rules about what a plan of safe care is. And so we at ILPQC created our own, what we felt comfortable with. And so when we started talking about this and reading the legislation, the question of what is a safe plan came up. What does it mean to say we in the hospital are discharging a baby to a birthing patient or a mother or a family, and we feel that this plan we've put in place is safe. And we didn't feel comfortable saying that we could call it a safe plan. And I really like the terminology family care plan to better describe this. But we wanted to develop a plan that addressed basic infant needs, that addressed infant developmental needs that we knew would be important, a plan that addressed maternal substance use disorder treatment, and that provided support for family and caregivers. So we said, okay, what does that mean? What does that mean to us? And we leaned on other PQCs, we leaned on hospital teams, we leaned on patients. We partnered with in Illinois, it's DCFS, which is the Department of Children and Family Services. And so we landed on coordinated discharge. That seemed the safest and realist to us at ILPQC. And we decided coordinated discharge meant clinical readiness. Is the baby ready to be discharged? Is the family prepared? Family preparedness. Are the mother, birthing patient, family, are they prepared to care for their baby at home? And then transfer of care. We're giving this care to someone else, a warm handoff, not only to the community pediatrician and to the OB that is taking care of the mother or OB patient, but also connecting families with community resources that are available. So we developed three tools to accomplish these three areas. We developed a mapping tool, and so hospitals were given these three resources: a mapping tool, a coordinated discharge checklist, and then a collaborative discharge plan. The mapping tool was to help hospital teams identify local resources for OENs and families. The coordinated discharge checklist provides clear guidance for a coordinated discharge. And then the collaborative discharge plan engages mothers and OB patients and families in their post-discharge plans. These are available on our toolkit. This is a snapshot of our toolkit. So I'm going to go through all three of them in depth. Completing the coordinated discharge mapping tool. So this was a tool or a form that hospitals have that is filled out by individual hospitals. So a hospital team would get this form and they'd fill out local resources for their hospital. It contains background information, some background information on various Illinois state resources and how and why and when to utilize each resources, and then the contact information listed for those resources. So for example, your hospital would get this form, and then they would fill out where are local early intervention offices, or where are early intervention offices that our patient population might use, who are local pediatricians that we know care for mothers and newborns that are affected by opioids, information about local health departments, local WIC offices and phone numbers and addresses, family case management, home visiting, early Head Start, crisis nurseries, just to name some. So each hospital team would go through a list and identify their local resources so that every time there was a mother and newborn affected by opioids, they had these resources compiled and could easily access any of these resources and get information to mothers and families. The second tool was completing the collaborative discharge plan. So with that mapping tool, we developed a collaborative discharge plan. And this is a discharge plan worksheet that the healthcare team and every dyad so not really the baby, but mothers, OB patients, and families work together, hopefully at infant admission, but throughout the admission and before discharge, to identify local resources. And so part of this is working with the mother and family to say, here is with that mapping tool, here's your specific early intervention office, here's your local pediatrician, here's where your local health department, and here are the resources that are available at the health department, and going down the list of things here. This tool is filled out with, like I said, the mother caregiver for all ENs. It's to engage and empower families and mothers and OB patients about the care and the process post-discharge. Some of the questions, in addition to looking at all of the resources available to them locally, we ask, what are your current supports? And so reflecting with mothers and OB patients on opportunities to, and using opportunities to engage in discussions of a dyad's current support, partner, spouse, family, friends, your MAT program, behavioral health counseling and recovery, spiritual faith, community services, recovery, community resources. So having a discussion with families and mothers and OB patients about what are current supports. What are your strengths and goals? So partnering with moms and OB patients to discuss their breastfeeding goals, their family and household strengths, food, either goals or areas where food is needed, transportation needs, safety needs, parenting goals, parenting strengths, parenting needs, housing, smoking cessation, and opioid use treatment and recovery. And so empowering moms by identifying their strengths and goals, but also identifying any needs. Who's your community pediatrician? So opportunity to identify the infant community pediatrician, and then allowing and facilitating a warm handoff for discharge. Understanding early intervention. What is early intervention? How will early intervention referral happen? And so discussing that and the importance of that with families. What are additional community resources? So identifying any additional community resources in the discharge mapping document that we talked about early that mothers and families may need or find helpful. And then lastly, completing the coordinated discharge list. Is a baby clinically ready? Is a family prepared? And have we done a transfer of care? Here is a sample of our checklist for clinical readiness, family preparedness. Here, just to highlight, understanding the collaborative discharge plan that I just talked about, the importance of breastfeeding, risk of visual problems, developmental follow-up, safe sleep practice, non-accidental trauma, learning CPR. In the neonatal abstinence syndrome, what you need to know, a guide for families, discussing stress at home and ability to step away from the baby, and resources and support that might be available. And then lastly, transfer of care, completion of the M&O collaborative discharge plan in partnership with the family and the community pediatrician. So now after the in-hospital part is done, partnering with the community pediatrician to have a warm handoff. And then lastly, coordination and clearance with our Illinois Department of Children and Family Services if needed. So we thought this work, we had outlined it and said, okay, a safe discharge, this is what it should be. This is what you should do. You should make sure the baby's ready to go home. You should call DCFS if needed, and then you should talk to the community pediatrician. And that was our first plan in where you see the arrow, Q3 2018. And we saw this flat line. Hospital teams said, okay, fine, we can do that, but we really don't understand what you want us to do. DCFS is a nebulous agency to us. We don't know when to call. We don't know why to call. We don't know what to say when we call. It seems to be call dependent. It seems to be county dependent. It seems to be area in the state dependent. And so our first PDSA cycle was really working with DCFS and community organizations to understand what needed to happen around discharge. But we stayed flat until, and then in Q1 2019, we said, okay, let's define and coordinate our discharge process. What is a coordinated discharge process? And that's where you saw some of the work that I just presented start to develop. We talked to other PQCs and leaned on their work and improved our toolkit, but still didn't see anything that was improving. We moved on to efforts and knowledge. We had webinars and really went through, we had DCFS come talk to people. We went through this checklist. This is what needs to be done for a safe discharge. And still people weren't getting this. Then we created our 3 discharge tools that we just went over. We used the same language. We went to teams. We had a webinar for each of the 3 tools to talk about exactly what they were. The most important seemed to be our teams needed more standardized guidance and truly more guidance. What do you want us to do for a coordinated discharge? As we saw with CAPTA and CARA and safe discharge, plans of safe care across the country and in the state, this was a very nebulous term. And once we started deciding this is what a coordinated discharge meant to us at ILPQC, and using the same language and the same tools and repetitive information, our hospital teams felt much more comfortable with the information and what it meant to have a coordinated discharge. And so, although we haven't met our goal, which we thought would be easy to have a coordinated discharge of 95% for all babies, should be able to have a coordinated discharge, we've really, aside from our Q1 in 2022, made some progress in what feels like babies going home with a warm handoff to the community. So at ILPQC, in summary, a safe discharge focuses on child vulnerability, adult protective capabilities, and safety factors. We wanted a comprehensive discharge plan that addressed maternal substance use treatment, a safe environment for both the mother, birthing patient, and baby, and parenting and community supports were essential. Our hospital teams implemented system changes and active clinical culture change to coordinate discharge planning in partnership with family care team and community pediatricians. They continue to do this with the 3 tools that I described. We now know at ILPQC that discharge planning starts prenatally. Having our local resources mapped at each hospital has made the discharge process much easier. And then completing this, standardizing our tools for every mother infant dyad has moved our needle. But our work is not done, as we heard this morning. This is data that you saw this morning, so I will not dwell on it. But opioid use and drug overdose deaths continue to increase. In the United States, there's been a 28.5 increase from last year. And that arrow there is when COVID began. This is the impact in Illinois. The arrow again is COVID. And there's an increase in drug overdose deaths in Illinois. And then here, as you saw this morning, is your Colorado data, also an increase in drug overdose deaths in Colorado. And we know that although this isn't maternal data, that with drug overdose deaths comes maternal overdose deaths, and then neonatal and increased maternal and OB patient substance use, and then neonatal opioid exposure. I don't have data from Colorado, but you saw that this morning because I don't have friends in Colorado at the Colorado Department of Public Health. But in Illinois, this is our maternal deaths due to opioids in Illinois. And from 2019 to 2020, pregnancy-associated mortality ratio increased from 10.7 to 21 deaths per 100,000 live births. We've seen a 96% increase in pregnancy-associated mortality in Illinois. So at ILPQC, our goal was optimal OEN care, every baby, every time. This is, as we all know, a tool go on day, but better is possible. It does not take genius. It doesn't take diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try. And this is what we saw at ILPQC with our discharge work. I do need to highlight Dan Weiss. He is our data and operations guy at ILPQC, and these tools and this improvement in our coordinated discharge is his baby. He did this, he created all of these tools and worked with teams to really improve our coordinated discharge. So he gets a huge shout out for all of the wonderful work he's done and all of the mothers, birthing patients, families, and babies that he has impacted. And these are our funders, and that's all I have. So thank you for having me here today.
Thank you so much, Dr. Caldarelli. That is truly inspiring. You know, we here in Colorado, our Chosen Quick effort, you know, it's been so hard to really hone in on the transitions and how to create systems that can ensure that appropriate services are in place, but also collect data around it. And so this was just really inspirational. Let's open it up for questions and discussion. I can get us started. You know, one thing here in our state that I've heard also in other states is that the maternal and the neonatal providers seem somewhat siloed in their efforts, that both are obviously very committed to this population, but really to create a seamless transition, really thinking about dyadic support, I think continues to be difficult. So wondering how your team addressed that, and if the care and the data that's collected is truly perinatal in spectrum, and if you have providers from, you know, both arenas really involved at every step of this effort.
So we, this was our first initiative doing something together. And so there were definitely bumps in the beginning of how are we going to coordinate this work. We try at our monthly webinars, we would have hospital teams present, and it wasn't always a neonatal team. They would have their OB providers present. We really partnered though at our face-to-face meeting, which is in the spring, and our annual conference, which is in the fall, and really tried to incorporate both an OB perspective and a neonatal perspective at our meetings. Our face-to-face meetings in the spring, we usually keep separate. And for M&O, we had common speakers and brought them together for the first time. At the hospital, so that's ILPQC Central, and then we had many more ILPQC as a state initiative. At ILPQC Central, we had many meetings together to talk about what was happening on the OB side. How do we join this together with the neonatal side, and looking at tools and improvement strategies and structure measures and what we needed to put in place, and then taking that back to the hospital teams and saying, okay, how do you, for example, do a prenatal consult? We know that a prenatal consult is important, but if patients aren't being identified and then connected to pediatricians, how can we do a prenatal consult? And so working with hospital teams saying, okay, prenatal consult is important. Let's talk about how individual hospital teams will do that at their hospital. And so giving examples of hospitals that were doing it well and hospitals that had struggles with it, and working together. So it was collaborative. So it was joining together at ILPQC. and then working on specific measures individually, and just instead of just saying, we're going to join together for this initiative, let's focus on prenatal consultation, for example, and then using hospital examples. And so really focusing on the small areas. People were also, as COVID started happening, taking small bites was a big focus. And so that allowed us to join together, if that answers your question. It's not easy though, because even at our hospital, the OBs have their meeting and we have our NEO meeting, and the two shall never cross. So I think it took some leadership, some example, and then some commitment on individual hospital teams to really join that together.
The question here from Cheryl King, and then I also see Ben Smith's hand up. So we'll start with Cheryl King's question. How effective was the warm handoff? Any data on the continuation of breastfeeding out to the community? Any readmission of newborns with withdrawal symptoms in the home setting?
So the babies kind of fall off when they leave the hospital. So we do not, as I'm sure is what I would expect is in Colorado, when they leave one hospital, babies don't necessarily come back to another hospital. We've worked a bit, they come back to a different hospital, and so it's hard to track readmission. And it's also hard to track readmission for opioid withdrawal, because they may not be coming, many people aren't coming to the hospital saying, my baby is still having symptoms of neonatal opioid withdrawal. So tracking was a problem and continues to be a problem, because there are so many hospitals in the Chicago area, so many hospitals in Illinois. And then we tried to work with IDPH to follow babies, but we don't have a system in place to know, to be able to connect their in-hospital stay to outpatient. And breastfeeding is the same. I'm hoping that it continues, but I don't have outpatient, or we don't have outpatient data.
Yeah, we're in the
You have suggestions on how to track, I'd love it.
Yeah, I think at the individual maternal infant dyad level, in real time, we can't get this data. The only way that we've been able to kind of do a workaround is looking at population level data, some vital statistics, hospital discharge data, but again, it's very retrospective. It's about a year or two lag. All right, Ben, I see you have your hand up.
Thanks very much. Dr. Caldarelli, this was an amazing talk. Really appreciate you pulling all this together. I'm a family medicine doctor up here in Northern Colorado. I work in an addiction setting, but also provide prenatal and newborn care. And so I'm really just excited to hear about all these possibilities of, circles overlapping and people communicating well and it being rich. And I think with those domains that we're working in up here in our practice, this residency practice where we work, we see a lot of the seams and exactly the kind of cracks that you're talking about, trying to help people not fall through. And that's one of the reasons why I think this THC question is so fascinating, because it brings out, especially in the setting of an opioid exposed newborn, when there really are competing benefits of exposure to maternal breast milk and a breastfeeding experience, and the presence of things that might otherwise be cautioned against. And so could you go into the development of that yellow section on the breastfeeding stoplight and kind of enrich bring some of that, or the richness to why that was framed up as yellow, and what kind of supports are available? Specifically, the way this has come to the head in our hospital system is that there have been women with opioid-exposed newborns trying to breastfeed who've been unable to access lactation support because of the presence of THC in breast milk. And it becomes this extremely complex, stigmatizing experience where moms are, trying to show up and trying to do their best. And then there's this systematic response that's very confusing. And so I just love to hear how it got yellow, because I think it's great that it's yellow. It seems like the right place for it. But I can imagine hospital systems making it red. And I would love to hear how you guys landed there.
We landed there because our initiative was created before a lot of talk has been happening. But we relied on you guys in Colorado to come talk to us and tell us what was best for breastfeeding and what was best for taking care of patients. So truly the answer is we landed there because of you guys and your guidance.
And I've seen some sort of back and forth with Dr. Wymore and others around breastfeeding. Erica, I was wondering if you can kind of elaborate on your comments that you've chatted in.
Yes, thank you very much. And thank you, Dr. Caldarelli. I know that I spoke to your group a couple of times.
Here she is.
And Ben, it is really hard. And I hear the struggle and the frustration and why this is so difficult. I think I chatted in kind of a long sort of comment. And I think really what we have to say is that if we don't address it, we're condoning it. And if we don't educate, we're condoning this. And the truth is, we don't have the data to say that breastfeeding with a mom who is struggling with opioid use and also concomitant marijuana use, that we don't know that which one is better. We don't know that risk benefit balance. The data is still unclear. And I think we want to be very supportive to mothers. So I think we have to find that balance of saying, we know that breastfeeding is great, but we are really concerned that your marijuana use could affect your baby as well as the opioid exposure. And I think we need to educate providers that we don't know the frequency and the dose and the potency of the marijuana use that mothers have. And the data that we do have in regards to pharmacokinetics is so wide. So how could I possibly tell mothers this amount of marijuana use is okay, but this amount is not? And we just don't have that data. So I think what we really need to say is, why are you using marijuana? How can I help you with those symptoms? And can we encourage you to abstain or at least decrease your use as much as possible, and really educate moms that we are concerned with the long-term effects of marijuana use. The more data that's coming out right now, we really should be cautious. Their longitudinal studies from 3-4 decades ago, they had some flaws, but the more recent data is really showing a concern. And I think we need to help educate our community that just because legalization is expanding does not mean that it is safe for these vulnerable populations. And I think that it is our responsibility as healthcare providers to keep echoing that message. We want to help you to reduce the use. We want to help you to stop using if you can, because we just don't think it's safe. I don't know if that's helpful.
I know yet this is another topic that could consume the rest of this forum, but let's pause there because it is time for a break. So we're going to take a 10-minute break, return at 11:25, continue with the rest of our session.